Her name was Marguerite. Marguerite Holloway, 74 years old, retired librarian from Savannah, Georgia, a precise, quietly elegant woman who had organized her entire life with great deliberateness, her bookshelves, her garden, her Tuesday afternoon reading group. A woman who believed, as most of us do, that when a doctor recommends a procedure, they have weighed every factor, and the answer is almost certainly yes. Marguerite signed the consent form for elective spinal fusion surgery on a Thursday afternoon. She went under general anesthesia on a Monday morning. She spent 11 days in the hospital, not recovering but fighting. Infection, complication on complication, blood clots, 3 return trips to the operating room in a single week. The surgeon had told her she would be back on her feet in 6 weeks. Her daughter Renee called me 3 months after the surgery. She had found my name through a patient advocacy organization. She was not angry, she told me. She was just trying to understand. She kept asking the same question, and it was a question I could not dismiss because I had heard it before in different voices, from different families, in different waiting rooms. Did anyone ever tell my mother she had a choice? Did anyone explain what could happen? Or did she sign because that's what you do when a doctor hands you a pen? My name is Dr. Michelle. I spent over 2 decades as a cardiothoracic surgeon. I have opened more chests than I can count. I have been that person in the operating room, the one holding the instruments, the one the family is waiting for. In this video, I am telling you today that there are 5 surgeries routinely recommended to seniors that fill operating rooms across this country every single week, where the evidence is far weaker, the risks far stronger, and the alternatives far more promising than most patients are ever told. I'm not here to frighten you away from medicine. Surgery saves lives. I have been part of that. I am proud of that. What I'm here to do is give you what Marguerite never had, the information she needed before she picked up that pen. Stay with me through all 5. Because surgery number 3 is the one that will surprise you most. It is one of the most commonly performed procedures in America, and it is one where the research has quietly been telling a very different story for years. Before we get to the 5 surgeries, I need you to understand something that most surgical consultations never fully address. The aging body does not experience surgery the way a younger body does, and this is not a small difference. This is a fundamental physiological difference that changes the entire risk equation. Think of it this way. When you are 40 years old and you go under general anesthesia, your body has an enormous reserve capacity. Your kidneys clear the drugs efficiently. Your lungs re-expand quickly. Your heart handles the fluid shifts. Your immune system rebounds fast. Your brain returns to clarity within hours. After 70, every one of those systems has less margin, less buffer, less ability to absorb the insult of being cut open, put on anesthesia, kept still for hours, and then asked to heal. Up to 40% of adults over 75 show measurable signs of clinical frailty. Frailty is a medical term. It means the body's physiological reserve has fallen below the threshold needed to safely absorb major stress. And surgery, even surgery that takes 2 hours and goes perfectly, is major physiological stress. There is also something called postoperative cognitive dysfunction, POCD. It is a condition where the brain, particularly in older adults, becomes temporarily or sometimes permanently impaired after general anesthesia. Confusion, memory lapses, personality changes. It happens in a significant percentage of patients over 70, and most of them are never warned that it might. And then there is what I call the cascade effect. One complication leads to another. A blood clot forms. Treating it causes a bleed. Treating the bleed requires a transfusion. The transfusion triggers an immune response. Each step is manageable on its own, but in a body with limited reserve, the chain can be very difficult to stop. I'm not telling you this to frighten you. I'm telling you this so that when a surgeon hands you a consent form, you understand the full picture, not just the picture of the surgery going well. Now, let's get to the main business of the day, the 5 surgeries. Number 1, surgery to reconsider elective spinal fusion for chronic back pain. This is Marguerite's surgery, and this is one of the fastest growing procedures in American medicine. Spinal fusion permanently joins 2 or more vertebrae in the spine using metal rods, screws, and bone grafts. The premise is logical. If movement between vertebrae is causing pain, eliminate the movement. The operation can take 3 to 7 hours under general anesthesia, and recovery is measured in months, not weeks. For the right patient, someone with specific structural instability, nerve compression causing paralysis, or progressive neurological damage, spinal fusion can be genuinely life changing. I want to be clear about that. But for the far more common presentation of chronic degenerative back pain in an older adult, the evidence is deeply uncomfortable for the surgical community. In patients over 65, complex spinal fusion carried a complication rate exceeding 40% in published data, and the pain relief was the reason the surgery was performed in the first place. There is also a mechanical problem that surgeons do not always explain fully before the operation. When you fuse a segment of the spine and lock it rigid, the vertebrae above and below that fusion now absorb all the movement that was previously distributed across the fused segment. Over time, they break down. It is called adjacent segment disease. Within 5 years of spinal fusion, a significant percentage of patients develop new pain at the adjacent levels, often requiring additional surgery. I think about Marguerite's daughter every time I see a spinal fusion consent form. About that question, she asked me, did anyone ever tell my mother she had a choice? The question to ask your surgeon. Before I agree to this particular surgery, have we exhausted all non surgical options first? What is my long term risk of adjacent segment disease? And is there a physical therapy protocol we can try for 3 months before making this decision? The alternative to consider a structured program of targeted physical therapy, core strengthening, epidural steroid injections if needed, and pain management has been shown in multiple trials to produce equivalent long term outcomes for degenerative back pain with zero surgical risk. Ask specifically for a referral to a physiatrist, a physician who specializes in non surgical rehabilitation now. The second is surgery to reconsider open heart bypass surgery for stable angina in frail patients. I want to introduce you to a man named Roland Kaczynski, 77 years old, retired architect from Cleveland, Ohio, sharp mind, dry humor, a man who had designed buildings that were still standing and still beautiful, and who approached his own body with the same architectural precision, managing his diet, walking every morning, keeping his doctor appointments without fail. Roland had stable angina. Chest discomfort during exertion is manageable, predictable, and controlled with medication. His cardiologist recommended a coronary artery bypass graft, open heart surgery, rerouting the blood flow around blockages in his coronary arteries. His daughter, who had driven him to the appointment, asked one question in the room. She asked it quietly, almost apologetically, as though she was not sure it was appropriate to ask. The cardiologist said, and I am using Roland's daughter's exact recollection of his words, we prefer to be proactive. What happens if my father does not have the surgery? She did not yet know enough to push back on it. Here is what that appointment should have included. Here is what the research actually shows. For stable coronary artery disease, bypass surgery showed no reduction in heart attack rates or mortality compared to optimized medical therapy at 5 years. The COURAGE trial, published in the New England Journal of Medicine, a landmark study of over 2,000 patients with stable angina. The word stable is doing enormous work in that sentence. For stable angina chest pain that is predictable, manageable, and responds to medication, the evidence does not support surgery as superior to well managed medical therapy in terms of survival or heart attack prevention. What surgery does offer for stable angina is symptom relief. For a younger, healthy patient who wants a better quality of life despite medication, that can be a valid choice. For a 77-year-old man with frailty indicators and multiple coexisting conditions, the equation changes entirely. Open heart surgery requires the heart to be stopped completely. A bypass machine takes over the function of the heart and lungs for the duration of the operation. For older adults, time on the bypass machine carries real and documented risks such as stroke, kidney injury, and cognitive impairment. Roland had the surgery. He survived it, but he spent 6 weeks in hospital and rehabilitation instead of the 2 weeks he was told. He developed confusion that his family describes as lasting nearly 4 months. His walking, which before the surgery was his greatest source of daily joy, became effortful and fearful. Roland told me at his follow up, "I feel like I went in one person and came out a different one." He was not wrong, and it did not have to happen that way. The question to ask your surgeon before agreeing to bypass surgery for stable angina: has my medical therapy been fully optimized? Has my frailty been formally assessed? And can we compare quality of life outcomes between surgery and aggressive medication management for someone with my specific profile? 2 surgeries in, and I need to pause here because if you are still watching, you are in the minority. Most people click away before they get to the information that could actually change a decision they are facing right now. So let me tell you what is still coming. Surgery number 3 is the one that will genuinely surprise you. It is a surgery so routine, so normalized, so thoroughly embedded in standard medical practice that questioning it feels almost radical. And yet, the data behind it, which has been published in peer reviewed journals for years, tells a story that almost none of the patients who have had this surgery were ever shown. Stay with me. Now, let's move to the 3rd surgery, which is the most surprising, shall. Gallbladder removal for silent, symptom free gallstones. This is the one that surprised me, even after 28 years. Because this surgery, cholecystectomy, the removal of the gallbladder, is so common, so routine, so reflexively recommended that the word routine has drifted from describing the procedure to describing the decision, and that drift is dangerous. More than 600,000 gallbladder removals are performed in the United States every year. It is one of the most frequently performed surgeries in all of medicine, and a substantial percentage of those operations are performed on older adults who had no symptoms whatsoever, whose gallstones were found incidentally on a scan ordered for something else entirely. I want to introduce you to a woman named Dolores Ferreira, 70 years old, retired pharmacist from Albuquerque, New Mexico, a woman who knew medications, who understood side effects, who read the labels. She had a CT scan of her abdomen ordered after a car accident. The accident was minor. Dolores was fine, but the radiologist noted in the report that her gallbladder contained several stones. Her primary care physician referred her to a surgeon. The surgeon recommended removal. The reasoning was presented as preventive. We should take care of this before it causes problems. Dolores, who knew medications but not surgery, assumed that if a surgeon was recommending it, the evidence supported it. She had the gallbladder removed laparoscopically, minimally invasive. The surgeon told her she would be back to normal in a week. 3 years later, Dolores still cannot eat a full meal without significant digestive distress. She has chronic diarrhea that she manages imperfectly with medication every day. The pharmacist who once counseled patients on digestive drugs now takes them herself permanently, she has been told, because without a gallbladder, the bile that was once stored and released in controlled amounts now drips continuously into her intestine. Only 1 in 5 people with silent gallstones will ever develop symptoms, and among those, serious complications are even rarer. Multiple prospective cohort studies were reviewed in the Annals of Internal Medicine on the natural history of asymptomatic gallstones. Read that again. If you have gallstones and no symptoms, the probability that you will ever develop symptoms is approximately 20%. The probability that you will experience a serious complication without intervention is lower still. Yet the surgical reflex is to remove the gallbladder before something happens. Before. Not because something has happened, not because the stones are causing any trouble, because they might. And here is what surgeons often do not fully explain. The gallbladder is not a vestigial organ. It has a function. It stores and concentrates bile and releases it in precisely timed quantities to aid the digestion of fat. When you remove it, that function is permanently gone. The body adapts partially, imperfectly, but for many patients, particularly older adults whose digestive systems are already less robust, the adaptation is incomplete. The chronic digestive consequences are real and they are life altering. Dolores told me something that has stayed with me since the day she said it. I was a pharmacist, I knew drugs, but I didn't know enough to ask whether the surgery was actually necessary. I trusted that if he recommended it, it was necessary. Nobody ever told me that doing nothing was a legitimate option. The question to ask your surgeon before agreeing to gallbladder removal: are my gallstones actually causing symptoms, or were they found incidentally? What is the statistical probability that watchful waiting with agreed parameters for when to act is a safe alternative for someone my age? And what are the long-term digestive consequences of gallbladder removal at my stage of life? Number 4, surgery to reconsider is arthroscopic knee surgery for osteoarthritis. I want to tell you about a man named James Okonkwo, 68 years old, retired civil engineer from Houston, Texas, a man who had spent his career building infrastructure and who brought the same practical, evidence-based thinking to his own health decisions. When his orthopedic surgeon recommended knee arthroscopy for his osteoarthritis, a procedure to clean out the damaged cartilage, smooth the rough surfaces, and wash the joint, James did what an engineer does. He asked for the data. The surgeon showed him before and after photographs. He described the procedure as low risk and minimally invasive. He told James that most patients felt significant improvement within 6 to 8 weeks. What the surgeon did not show James was a particular study, a landmark study, one of the most clearly designed and most uncomfortable clinical trials in orthopedic medicine. Arthroscopic knee surgery for osteoarthritis provided no additional benefit over sham surgery, a placebo procedure, at 2 years. New England Journal of Medicine, double-blind, randomized controlled trial, arthroscopic knee surgery versus placebo, sham surgery. Patients who received anesthesia, had incisions made, and had the instruments inserted and removed without any cleaning or smoothing of the joint reported the same levels of pain relief as patients who received the actual surgical procedure. The same levels at 2 years. This finding has been replicated. Multiple independent trials across multiple countries have found the same result. For osteoarthritis of the knee, the most common reason this surgery is recommended, arthroscopy does not outperform non-surgical care in terms of pain, function, or quality of life over time. And yet it remains one of the most commonly performed orthopedic procedures in the world. James, to his credit, pushed back. He told his surgeon he wanted to read the research first. His surgeon was not pleased. But James was an engineer, and engineers do not approve designs without reviewing the specifications. James spent 12 weeks in a supervised physical therapy program instead. He lost 14 pounds. His pain level, by his own self assessment, improved from a 7 out of 10 to a 3. He sent me a note 6 months later. It said simply, "Still walking, both original knees intact, nobody cut anything. I think I made the right call." He did. The question to ask your surgeon before agreeing to knee arthroscopy: is my diagnosis osteoarthritis or a specific mechanical problem like a meniscal tear? Have I been shown the randomized controlled trial data on arthroscopy for arthritis? And has a formal supervised physical therapy program been tried first? Number 5, surgery to reconsider. Aggressive cardiac device implantation in advanced frailty. This is the hardest surgery on this list to talk about because it involves not just medicine but values, not just evidence, but the question of what a person wants for themselves at the end of life. I want to tell you about a woman named Frances Donnelly, 82 years old, retired nurse from Portland, Oregon. A woman who had spent her career in end-of-life care, who had sat at bedsides, who had held hands, who had understood from decades of professional experience what dying looked like and what living looked like, and the vast important space between the two. Frances had advanced heart failure and had been told she needed an ICD, an implantable cardioverter defibrillator, a device that would detect dangerous heart rhythms and deliver an electric shock to restore normal function. Her cardiologist presented it as straightforward, standard of care, something that could save her life. Frances, who had spent 30 years watching patients receive aggressive interventions in the final phase of life, asked a question that surprised the room. If this device fires when my heart is failing, from something else entirely, not a rhythm problem, but my heart just wearing out, what will that feel like? And will I have any say in when it stops? The room went quiet. Here is what Frances understood from her years at those bedsides that many patients never learn until it is too late to matter. Before you leave, I am asking 4 things of you, not for me, for Marguerite, for Roland, for everyone who signed a consent form before they had the full picture. First, subscribe to this channel. I share information like this every week, the kind that takes longer than a surgical consultation to properly explain, the kind that belongs to patients, not just to the people holding the instruments. Second, like this video. That single tap is what tells the algorithm to show this to someone else, someone who has a surgical appointment next week and does not yet know what questions to ask. Your click may be the thing that gets this video in front of them in time. Third, leave a comment right now. Tell me which of these 5 surgeries you or someone you love has faced. Type the words "before I say yes" in the comments if you are committing to asking these questions at your next consultation. And fourth, please share this video. Share it with a parent who has a surgical recommendation sitting on their kitchen table. Share it with a friend who is about to sign a consent form. Share it with anyone who deserves the full picture before they are asked to pick up a pen. Surgery saves lives. I have been part of that. I believe in that. Before you say yes, know what you are saying yes to. This is Dr. Michelle. I will see you in the next video. Medical disclaimer. This video is for educational and informational purposes only. It is not a substitute for professional medical advice, diagnosis, or treatment. Every patient's situation is unique. Always consult your physician, surgeon, and relevant specialists before making decisions about surgery or medical treatment. Do not delay or disregard professional medical advice based on content in this video.